Let's turn this off. Recording transcribed in.
She knew about it. I mean, I think it's a problem.
Okay. So, perfect. Now we've got a red border. So the purpose of today is to talk about anterior shoulder instability. As everyone I think in the room already knows, 90% of shoulder dislocations are anterior, and mostly they come to the ER like this, which is to say that the head is anterior and inferior. They're generally not straight anterior because the coracoid's in the way. Occasionally we do see coracoid fractures with more of an anterior superior direction, but the vast majority of these are anterior inferior. And then once reduced, often the x-rays are relatively normal other than the Hill Sachs. Okay, the general concept here and the general, I think, reason why this occurs is that the shoulder, as you know, is this is a ball and socket, but the socket, there's almost no curvature at all to the glenoid. So this is the reason why, like, if you think about like the skeleton in your first grade classroom, there's like a bolt that holds the humerus to the scapula because there's really no inherent stability of the shape of the bones. Like the shape of the bones, unlike the elbow where the bones fit together very nicely and that provides a great deal of stability, the shape of the bones themselves provides almost no stability. The secondary, so it's often described as a, less like a ball and socket, more like a golf ball and a golf tee. And this isn't an axial slice from an MRI that demonstrates that. So you can see the glenoid itself, which is the thicker white line. Again, it's like that's a straight line drawn by the computer. It's basically completely flat. Whereas the curvature comes from the cartilage. And this is the general reason why there's what's called a bare spot. The bare spot in the center of the glenoid is because there's actually almost no thickness to the cartilage in the middle, whereas the thickness to the cartilage at the periphery is on average about 4 millimeters. And then the labrum itself increases that depth. And then attaching to the labrum is the capsule. So thing number one is that the cartilage also contributes to stability by creating more concavity. So that actually contributes to stability. So this is from a biomechanical study we did showing that if you create a Bankart lesion, there is some increase in anterior translation. But if you create a Bankart lesion and then you also add a chondral defect, there's a dramatic increase beyond that. So anterior chondral defects are very destabilizing in addition to anterior inferior labral tears. Okay, now the concavity itself, because it's so shallow, is dependent upon the force of the rotator cuff to pull the ball into the socket. And this is what's been termed the concavity compression mechanism. And this mechanism is very basically what you need to understand about the way the shoulder works, is that the rotator cuff pulls the humeral head into the concavity of the glenoid fossa, and that pulling creates a stable fulcrum so that you can rotate the shoulder. This allows larger muscles like the deltoid and the pectoralis to really apply force through the joint without translating the ball relative to the socket. So this is the reason why rotator cuff tears are so problematic for the shoulder, right? Because once you lose portions of that stabilizing mechanism, then all of a sudden the ball is no longer stable. So like, for instance, yesterday we fixed a gentleman with a massive superior and posterior rotator cuff tear, and one of his complaints is instability, which is he says, my shoulder keeps dislocating. We do see that occasionally in older people. More frequently, what you see is because of loss of the infraspinatus or the top portion of the subscapularis, you get superior translation. You all know this as proximal humeral migration. All these are essentially manifestations of instability, which again are because the rotator cuff is a stabilizing mechanism through its interaction with the concavity of the glenoid fossa. So again, this balance force couple is because both the subscapularis, the infraspinatus, the supraspinatus, all of them pull immediately on the head. Okay, so we've showed this also in a biomechanical study. This again has not been published yet, but muscle forces are critical for stability, and that as you add more pull on the rotator cuff, you can see that you get less translation, and as you have kind of subscap minus 60, you can see there's an increase in translation. If you have both subscap and infraspinatus minus 60, you can see that that is additive overall over just losing the subscap or just losing the infraspinatus, which, as you can see, are roughly equal in terms of their destabilizing effect. Both of those are beyond just the Bankart. Because the other thing is the labrum itself. So the labrum has this, as it deepens the fossa, but that's actually probably, at least in my opinion, not its most important effect. Its most important effect is that it acts as a suction cup. So one of the stabilizing mechanisms of the shoulder is that there is an negative intra-articular pressure. So if you place a spinal needle on the shoulder, there's actually a vacuum within it. Now, if you lose that vacuum is created by the labrum, and the labrum again is a suction cup. So the rotator cuff pulls the humeral head into the glenoid fossa. That widens the edges of the labrum, and it creates a suction cup there. And then that creates that negative intra-articular pressure. So the labrum is the mechanism behind which you create a negative intra-articular pressure. That negative intra-articular pressure itself also aids in stability of the shoulder. Now, when you have any kind of labral tear, you lose a little bit of this. And this is one reason why, at least in my opinion, the slap tear is probably a precursor to osteoarthritis. Because you develop the slap tear, you lose the suction cup, you develop microinstability. The microinstability contributes to chondral damage later in life. So this is just a demonstration. This is a suction cup from one of my children's bath toys. You can see it's flexible, just like the labrum is. This is a ball from another one of my children's toys. And you can see that that creates this kind of perfect suction cup. And then if I try and translate the ball, right, the suction cup holds the ball in place. So this is the mechanism whereby that negative intra-articular pressure creates stability. And if you lose one part of that, for instance, if you have an inferior labral tear, and that labral tear heals medially, then all of a sudden you have instability. But interestingly enough, you have instability in the opposite direction. So if you try and push posteriorly now, all of a sudden you have that issue, whereas you actually have preserved stability in the opposite direction. So this is, what I'm trying to say here is that anterior-inferior labral tears can create posterior instability, and posterior labral tears can create anterior instability because of loss of the suction cup phenomenon, which works in the contralateral direction from the direction whereby the labral tear is. So this is a mechanism whereby posterior superior labral tears can contribute to anterior-inferior instability of the shoulder. This is just a video showing the same concept, that if I'm pushing posterior, that anterior labral tear is creating instability. Whereas if I'm pushing anterior, that anterior labral tear is not necessarily creating instability. And this is a demonstration biomechanically showing the same stability ratio, and we published this in the Journal of Shoulder and Elbow Surgery again, that labral tears create instability in opposite directions. The other mechanism for stabilization is the capsule itself. So the capsule itself has thickenings within it. We call these thickenings ligaments. They're nothing more than that, thickenings within the capsule. Portions are thicker or thinner than others, and we've named those thickenings. But you can understand by the way I'm describing it, there's some variation within that, and that to say as though there is some specific band that is the anterior-inferior glenohumeral ligament, like that's just the leading edge of the inferior glenohumeral ligament. And that was demonstrated by Debsky in a pretty careful biomechanical study. But basically the ligament that is most important for stability is the inferior glenohumeral ligament. It acts like a hammock, like a sling that holds up the humeral head, as you can see here. And what happens is as you rotate the shoulder, it's tensioned differentially. So when you rotate into external rotation, it tensions the anterior part. When you rotate into internal rotation, it tensions the posterior part. And this is kind of like, if you can imagine wringing out a towel. When you wring out a towel, you create the same effect as when you rotate your shoulder. And this is the reason why, for instance, and you could do this experiment on yourself. If you try and abduct your shoulder, you have more abduction motion in neutral rotation than you do in external rotation or internal rotation, because that wringing pulls the shoulder down. So this is the same reason why, like, if you bring your arm all the way up into full active forward elevation, you have almost no humeral rotation, because again, you've maximally tensioned the inferior glenohumeral ligament. Does that make sense? Okay. So this is the cadaveric demonstration of the inferior glenohumeral ligament, and you can see I've kind of pulled it all the way up, and that creates that kind of ringing across the bottom that I was trying to describe. Okay, so what happens then when the shoulder dislocates? This was pretty carefully studied by Dean Taylor. This is probably the most important study Dean Taylor did in his whole career. He did this in the military. Basically what they did is every cadet within West Point If they dislocated their shoulder, they had to see Dean Taylor, and then Dean Taylor scoped their shoulder for every single cadet, I think for 2 years. And then he basically just documented what they found. So I don't know how you get this through the IRB, but somehow the military allowed them to do this. And they had 63 of them. All of them were scoped within 10 days of injury. So very quickly, this is much quicker than we typically scope patients with shoulder dislocations. 97% of the time there was an anterior inferior labral tear. The other 3% of the time there was a haggle. So in 100% of patients with traumatic shoulder dislocations, there was a disruption somewhere between the glenoid and the humerus in the inferior glenohumeral ligament complex. I sometimes call it the labroligamentous complex. 90% of them had Hill sacks, and about 10% of them had slap tears. Now, this complex that I just described, the inferior glenohumeral ligament complex, it has a couple of different aspects to it. It has its humeral attachment, and has the capsule itself, and has its labral attachment. The labrum then attaches onto the glenoid. That attachment sneaks down the neck a little bit in the periosteum, and then it also attaches on the chondral surface. And depending on where you tear that complex, we have a bunch of different names for that. So if it involves the cartilage, we call it the glad lesion. If it's just at the labral-chondral junction, we call that the Bankart. If it extends down the periosteal extension, we call that the Alpsa lesion. If it occurs at the labroligamentous attachment, we call that the gaggle. If it occurs within the middle of the capsule, we call that a capsular tear, capsule stretch. If it occurs at the humeral attachment, we call that the haggle lesion. All those are different names for tears within the same structure. So it sounds like a complexity, but it's really not that complicated. Okay. So this is what that typically looks like on an MRI, where you can see that anterior inferior labral tear. And I will just say that that one of the things that I think actually drives people away from shoulder is that testing for this lesion on physical examination is not easy. It's challenging, and there are like hundreds of tests that have been described to be able to ferret these things out. This is like a short list of them that I found in the literature. These are the ones that I actually find useful. I find the apprehension test to be relatively useful. You bring the arm up into this position, and I usually just do it standing and say to the patient, does this make you nervous? Then the patient has a positive anterior apprehension test. If you then push posteriorly on the humeral head and say, does that make you feel better? That's a positive relocation test. Those to me are the only two tests that I use for anterior instability. The anterior drawer, or the anterior glide, or the surprise test I do not find useful. I find Kim's test to be relatively useful for the posterior, and the basic idea is it's basically the opposite. So this is abduction, extension, external rotation. Kim's test is adduction, flexion, internal rotation. So it's just the exact opposite. And then you push posterior of the humerus and anterior on the scapula, and you bring the arm from this position back into a more abducted and externally rotated position. And if you can create a grind or a sensation of instability or a pop in and out, that's a positive Kim's test. The superior shear test is basically the same thing, but in a lower degree of flexion to try and ferret out posterior labral tears. The Gage maneuver is probably the only maneuver that's particularly useful for the haggle lesion. And again, Debsky showed that in his biomechanical study. The basic way you do that is you test the patient's passive abduction on both sides, and you want glenohumeral abduction. So you hold down on the scapula, you abduct the humerus, and then you see what happens at end range. So this is just some pictures of those. This is the anti-apprehension test. Again, I usually do this with the patient standing instead of lying down. And then you can see in the bottom right, the relocation test. This is a demonstration of Kim's test, sometimes also called the crank test or the posterior apprehension test. And then with the patient under anesthesia, I'll always examine the shoulder instability, and usually you can dislocate the shoulder as you're seeing here. You can go in, out, in, and I find this. You can also test the back, and again, these tests I found to be useful in the OR, but you should be like I'm not examining patients in the OR routinely unless I've already planned to do a labor repair on them. But if you examine the shoulder under anesthesia and it's stable, it may change the way you feel about what you're going to do in the operating room. So I do find this to be somewhat useful. That being said, you're already in the operating room, so it's not like I'm going to do this 5 minutes stable and then not scope the shoulder. So, the last thing we use physical examination tests for is determination of multi-directional instability or ligamentous laxity, and some people will use Baton score. I personally have just been looking for shoulder instability isolated to, or hyperlaxity isolated to the upper extremity on my exam. And the way to do that is to look for passive external rotation and adduction on both sides. And if on the contralateral side, you know the person is 110 degrees, then you know they're hyperlax. And then also to look for hyperextension at the elbow. I think that these are just a little bit more like the thing with the thumb and putting your hands on the floor and all the other Baten's things. Like I have trouble remembering what they all are. And more importantly, I do think there are patients that have hyperlaxity that's more specific to the upper extremity. And I think that the genetics of that are just not well ferreted out, to be honest. So anyway, this shows that hyperextension at the elbow.
Can you demonstrate the superior shear?
Yeah.
Peter, do you think it matters if you do those laying back understanding?
Apprehension or?
No, those two tests.
I don't think so. Do you do the lay down?
I do all the ways the first level. So I do exactly the same ones. You guys have seen in the clinic that do anterior apprehension, location, and then I do basically the equivalent of a Hughes test, which I would say will posterior apprehension, which is doing exactly the opposite. And more abduction, and then just the slip when I push up and basically rotate the fingers, start having pain posterior as assess the posterior superior. So almost identical. All the tests are real. It's just that I can do them all laying down instead of actually.
It takes a couple of minutes for the patient to lay down.
Yeah.
I'm
not sure if it matters.
I don't know that it matters. Yeah. But basically, I do this test is I'll put my hand on the scapula here, bring the patient into elbow flexion, which just better allows you to control the humerus. And the idea is you push down here and up here, and you come gently through like this. See, you're resisting me.
I know.
Does that hurt you?
No. I now
You
realize.
slapped her?
No, I now realize why patients have a hard time relaxing when we ask them to.
Just relax.
What do you think about O'Brien's and DLS?
Yeah, so your superior labrum seems to be attacked. And then more up here is more posterior inferior. You have a little bit of a shift there. Does that hurt?
So you're just kind of like taking
Yeah,
him
look
through
this is the other reason why.
wax.
Yeah, I mean you can actually rotate it to like 110 degrees. So this is the problem is once you're hyperlaxed, like it's hard to figure out like is that the labrum or the capsule that's.
Yeah. So you're just applying axial load superiorly and then kind of like taking him through a little bit of adduction and kind of rotating.
That's what I'm
Trying to catch the labrum a little bit.
That's what I'm trying to do, yeah.
Okay.
That makes
Do
sense.
you use O'Brien's and DLS?
I use both of them, and I don't think either of them are particularly useful. But I've thought about stopping, but I only use them if in that specific and you think it's a slap hair connotation, you know. The DLS in particular, I thought I'd stop using because I think it's almost useless. Okay, so this is the challenge. Is if you look in the literature, these are the described treatments for anterior shoulder instability. And it becomes like very unclear, like when do you do each of these things? Like when the patient's treated non-operatively. You'll hear people on the podium say the open Bankart is the solution and we've just all forgotten how to do it. You'll hear people like Ivan Wong say every patient needs a distal tibial allograft. So it's very unclear like when you do each of these things. So I wanted to go through some of the literature and then try and describe my treatment algorithm. So here's thing number one that you should know, and I'm sure you guys already know this. This is old literature, but it's something you should know, which is that there have been multiple randomized clinical trials that have randomized patients either have surgery in which the labrum is repaired or not have surgery. And all of them show the same thing, which is that doing surgery for a first-time dislocator dramatically reduces the likelihood they will dislocate again. So this literature is very useful. I tell patients this when they come in and have a dislocation. Even if it's one dislocation, if it's a high schooler, I say, you should really consider having a surgery because surgery dramatically reduces the likelihood this will happen to you again. Now,
Before you go beyond that, you said, so say that it's a 65% dislocated shoulder sleeve, you say.
I don't because of this. So these are the risk factors that Pascal described for recurrence with arthroscopic repair, and I've been also applying them to the first-time dislocator, which is to say, I look at the patient and try and figure out what their risk is, and these are the factors that I try and use. So patients that are young, and I've been using 22 instead of 20 because I think 22 in American society is like when you graduate from college and kind of become an adult, and that's the point at which most people spend most of their waking hours working and fewer of their waking hours, you know, playing intramural football. What are your athletic activities? And around here, of course, the ones we worry about are like mountain activities, but you definitely will see people who are like, oh yeah, I play volleyball every weekend. I'm like, okay, this is a higher risk person. What kind of sport it is? Definitely a contact collision sport is higher risk. Do they have some hyperlaxity? And then those two bone loss ones are harder to use. That's much less common with a first-time dislocator. But if there's a first-time dislocator and there's a glenoid fracture, that definitely for me plays into the algorithm. So if you come in and you've only had one dislocation, but there's a bony Bankart, I try and be more aggressive with those, even in slightly older populations. So if someone's early 30s, I might be a little bit more nervous about that than I would be if someone's in early 30s. Truth be told, shoulder dislocations are bimodal, just like most of trauma, in that they either occur in young patients or in old patients, and we treat those patient populations very differently. Basically, the story with that is I can just summarize it for you. Most of what I'm talking about in this talk is young patients. Older patients are totally different. There's three things I worry about in older patients: broken bone, torn rotator cuff, injured nerve. If you have none of those things, and you have one shoulder dislocation, you get treated non-operatively. And then the treatment of those things individually, we can talk about in other talks. Okay, so let's talk about if you're going to do the surgery, the labor repair. I want to talk about this first because I think that it's continues to be one of our mainstays in the treatment of shoulder instability. Generally, what I will do is act as though the glenoid has a clock face on it. For me, anterior is always 3 o'clock, just because it makes it easier for me to try and not figure out which side is right or left. And these are generally the portals that I will use. So I try and do most of my viewing from anterior superior. I will do most of my suture passage from anterior, and then I will place anchors from 5 o'clock and 7 o'clock, and then pass sutures. And the spectrum usually comes from 7 o'clock and from anterior. The posterior portal is useful for suture management and also to get you started. And then if you have to place anchors posterior superiorly, I use Wilmington for that. So this image comes from this paper that Romeo wrote called the Roadmap to the Glenoid that was like really helpful to me in trying to think about how to do this surgery. So these pictures are Yankees pictures, so I credit goes to Yankee for that. So for me, this is how I do most anterior inferior labor repair. Anchors come from 5 o'clock, spectrum comes from 7 o'clock until we get to the top when spectrum comes from anterior. For slap repair, usually the anchors come from Wilmington. This also has anchors coming from ASL, and I very infrequently do that because it tends to put the anchors very anterior where I don't like them. And then sutures will get passed usually from anterior superior or anterior. For posterior labor repair, usually you can do almost all this from 7 o'clock or the posterior portal, as is shown here. There are a bunch of different ways to do this, and there's descriptions in the literature of simple stitches. Some people think mattresses are better because it puts the labrum more on the face. Some people will do a combined mattress and simple suture, which is something called the amoeba stitch, and there's at least one biomechanical study from Milan suggesting that's better, but even the people in Milan don't really seem to think it works that well. I like simple sutures, and the reason I like simple sutures is because the labrum has circumferential collagen fibers. So when you place simple sutures, you get the best bite in the labrum because you go around those. I think it also helps to make a bumper, and I think that it really simplifies suture management during surgery. So I've just been using all simples. I don't know if that's wrong, but that's what I'm doing. This just shows those same portals, kind of an arc around the shoulder, giving you access to the whole glenoid. And this is pictures from surgery showing the same thing. Here's your labral tear. This is pulling it reduced. This is once it's been repaired, and you can see kind of each of these are double loaded anchors, so the sutures kind of come as a V from each one. And to do this, usually for me, if it's like the whole bottom of the labrum, it requires 4 spectrum hooks. So I usually will use the 45 going to the right, the 45 going to the left, the crescent, and the 45 straight. Those are the 4 hooks that I'll use. All 4 of these hooks will fit through a 7mm cannula, which is shown up here. So for me, that simplifies my life substantially. I just use, for every case, the 7cm by 7mm cannula. It works for cuff repair, it works for labor repair. And if I say open a cannula, no one ever has to ask me what kind of cannula I open it on. It's like, that's the only kind of cannula we ever use. But there are other spectrum hooks that are, there's one called a 90-degree that looks more like a corkscrew. That does not fit through this cannula, and you need the 8mm cannula for that one, which is the one that has the purple thing going through the middle of it. So are you using, Bob, other spectrum hooks, or are these before you used to?
I actually just use 3. I just use the crescent. Right.
Oh, you never used the 45 straight, really? I like that one. Huh.
I guess if you're depending on. Then I'm also using drills. So Arthrex has.
The disposables.
I use those because 2 reasons. One, oftentimes,
Mm-hmm.
so if you have troubles penetrating through tissue, diameter is longer. So the core diameter, the outer diameter is actually bigger, therefore it's stiffer.
Mm-hmm.
It's almost physically impossible to break.
These are definitely breakable.
Yeah. So a lot of times,
This is the hardest instrument to use in all of shoulder surgery, just so we're clear. It's like I never successfully used this thing as a resident. It's very hard to use. It's very useful. So the challenge becomes if there's bone. If you catch the bone acutely, then you can go around it just like it was a portion of the labrum. But if you don't catch it acutely or the patient decides not to have surgery, often these pieces resorb and then you end up with bone loss of this inverted paraglenoid. And the problem with this, of course, is it's hard to see on a general x-ray. You can have an x-ray that looks relatively normal. You need this kind of specialized Bernageau view to really see the bone losses. This is not something we routinely obtain because instead we've all moved to CT scan. And even CT scan is hard to interpret. What you really need on the CT scan is you need a 3D reconstruction with the humerus subtracted, and then you need an en-face view. So you don't want the plane of the body, you don't want the plane of the scapula, you want perpendicular to the glenoid face to actually be able to accurately measure this. And then even how to measure it is something that we don't agree upon. So these are some of the different methods that have been used. You can see they provide different numbers. So we've actually looked at this. Not only do these provide different numbers, so linear measurements are greater than area measurements. CT measurements tend to be greater than MRI measurements. And this is data from a study that we published in Arthroscopy. So basically what I've been doing is if you get an MRI and the bone loss is kind of like in the middle, like maybe it's between 10 and 20%, then you should get a CT and go through this whole rigmarole of getting the 3D reconstructions with the humerus subtracted and getting it so you can rotate it so that it's perfectly en face and making your measurement. But if it's almost no bone loss on the MRI or there's clearly bone loss in the MRI, then it probably is not going to make a difference. So if a difference of 3 to 5% is going to make a difference, then I'll say you need a CT in addition to the MRI. Now, obviously, the patient with bone loss you traditionally think of as this patient, the patient who's had, so many locations that they can kind of shift their shoulder like that and it just goes right back in. Or the patient who says, like, when I bring my arm up into this position, even in a gentle degree of flexion, abduction, rotation, that shoulder is going to dislocate. And the reason why this is important is because that patient that I just showed you is definitely going to have critical bone loss. And that traditionally is the patient that we've said needs a bony augmentation procedure. We've now moved into this kind of subcritical phase. And the reason why is because of this study that JT Tokish did that's been replicated since, showing that even more mild degrees of bone loss, like even the patient with 16% bone loss in this study has an increased failure rate over the patient that has 10% or less bone loss. So of course, then for the patient with bone loss, traditionally we've done is the Latarjet, and of course you cut the coracoid, you split the subscap, you prepare the glenoid, and then you screw the coracoid to the glenoid. And if this all goes well, then this procedure works really well. But the problem is there's really a lot that goes wrong with this procedure, just to be perfectly frank, that definitely done incorrectly, you can have screws in the joint, you can have grafts that pull off, you can have the graft break, you can have the graft be prominent in the joint, you can have the graft not heal. There's like so much that goes wrong with this procedure. And then the thing that goes wrong that's and these are young patients, so often, as you can tell from these pictures, there can be complications which lead to further arthropathy. So then you all of a sudden have a 25-year-old patient with arthritis, and like now you have like an insolvable problem. Or the thing that we fear the most with this procedure is a neurologic deficit in primarily, most commonly, the axillary, the muscocutaneous nerves. So again, like that's the reason why everyone's scared to do this. Before we talk about that, I wanted to talk about why would you consider doing this? And there are a lot of studies with long-term follow-up. So these are, I split these studies into two groups. This hasn't been published. This is just analysis I did for myself when I was in Europe. Because in Europe, they were all like, why are you Americans so stupid and you're not using the letter J? So there's 26 studies that I could find that had more than 5 years minimum follow-up, either with the Bankart or the ladder J. And this is them on a graph. You can see it's a lot of patients, about 1,600 patients in all these studies. The mean recurrence after ladder J is 9%. So it's not perfect. And like the Bankart, the longer you follow the patients, the more failures you see. So the longest term follow-up, ladder J here is orange, does have this kind of higher risk of recurrence. But you can see on average, those patients are down here, right around 10%. Whereas with the Bankart, the mean recurrence is 30%. And you can see that here with kind of these other dots that are on average somewhere right around here. And so that's the issue, is that it's pretty clear that the ladder J is more powerful in stabilizing the shoulder than the Bankart is. So if we get the ladder J to work better, then that would probably be the ideal. So these are the things that go wrong. The graft, if it's too lateral, you get arthritis. If it's too medial, you still have instability. The subscap can rupture. You can get an infection. You could damage, again, the axillary muscocutaneous nerves. You could have a non-union. The screws can be malpositioned or pull out, or the screws can be in the joint. If you have to go back, then things get scary because you no longer have the straps as a guide to where the plexus is. And a lot of people say that this is disrespectful of the capsular soft tissues and does not address the Hill Sachs. So these are the general things that I've been trying to do to improve upon it. So thing number one, I think that you definitely need exposure to make sure your graft is in the right place. So during this operation, it's really critical you can see the joint line, so you know exactly where your screws are going to go, and so you know exactly where the lateral aspect of graft is going to go. One of the things that's nice about Ivan's procedure is it goes through the interval and you no longer worry about the subscap. There's questions as to whether autograft is better than allograft, and I personally think this is somewhat of an open question. If you look in literature, the historic use of allograft crest is like, it's abysmal. And the allograft results of distal tibia seem to be better. It's very different bone. It's unclear if that's a short-term thing, I think, because we don't have 10-year outcomes on distal tibial allografts, but thus far it seems to work better. If we could do this arthroscopically, that would be better. And then I've tried to drill from the back to avoid nerve injuries, and I think I'm done with that because that just did not work. And optimizing fixation, I think, is a lot about getting your screws right. And then there are patients that I think do benefit from a combined ladder J remplissage, and that's something that I think is a little bit easier if you try and do this arthroscopically. So you can see a lot of these things are kind of fixed by Ivan Wong's technique in that it's arthroscopic and subscap sparing and coracoid strap tendon sparing, and it's fixed with screws, and it allows you to easily add a labor repair and remplissage. And these are his results, which is that a mean follow-up of about 5 years, he had no dislocations. He says he has a 100% union rate. You guys have watched me do this. I think that it overall works well. I personally am not 100% satisfied with the graft position you could achieve through this technique. And I think that it's very hard to get the graft where you want it to go. And on the x-rays, sometimes the graft looks like it's angled more laterally than I'd like. But thus far, I will say, other than one muscocutaneous nerve palsy that resolved, I've actually also been pretty happy with this technique. So I'm not sure if this is the future. Certainly Latarjet works well. I think it's totally reasonable to just do a Latarjet, but this is the direction in which a lot of people are going right now in the field for the reasons that I've just discussed.
Peter, what is just putting our stuff out? Because the benefits of autograph, which is, it's, you know, it's clear, awesome, and that's all. So just gonna do stuff about it. So,
George told me he thinks it works really well. I talked to him about this for a long time in India.
he doesn't know open.
Right.
There's still some things.
Well, the same Grant's doing the same thing, you know. Grant says he's done both the arthroscopic Latarjet and Ivan's technique, and he thinks that Ivan's technique is easier. Part of the concern I've had is that I've done probably 5 arthroscopic Latarjets in the lab now, and I think it's really, really hard. I think it's really hard because you have to work very medially in front of the subscap, and that's something you don't have to do with Ivan's technique. I guess one of the primary concerns I had about the arthroscopic Latarjet is, like, I'm at the point now with Ivan's technique where I can feel comfortable with one of our fellows going out, like I could teach them that and they can go out and practice and do it. I don't know that I'm gonna get to that point with the arthroscopic Latarjet. Like, I'm not sure if I'm ever getting to the point where I'm gonna comfortably say, you're gonna do 3 with me and then you're gonna go out and not cause problems, you know? So I don't know. I've thought maybe I'll go back and just do that. I mean, there's other people like Paul Favorito, that's like all he does. And when I went to India, there were like all these Indian surgeons, they were like all doing arthroscopic Latarjets, and I was like, wow, this is crazy. But using screws, all using diffuse set, yeah. Okay, so the basic idea behind the Hill-Sachs is this. The Hill-Sachs is posterior superior on the head. If you're missing a little bit of bone from the anterior glenoid and a little bit of bone from the posterior humerus, then those 2 things can engage and then the shoulder dislocates. The way to make these measurements is you measure the width of available glenoid, you measure the width of the Hill-Sachs, you multiply it by the magic number, which is 0.83 according to Nobuyamoto, and then if one is bigger than the other, then the shoulder's off tract. Okay, so there's a bunch of problems with this. Problem number 1 is, how do you make the measurement on the humerus? And I'll show you that difficulty in a second. Problem number 2 is the magic number, which is probably different for every patient, and has to do with how flexible the patient is and to at what angle the Hill-Sachs is relative to the humeral head. So, but this is a basic way that you're supposed to make these measurements. And then supposedly, if the shoulder's off track, you're supposed to add the remplissage. The remplissage is actually pretty easy. This takes like 15 minutes. There is the occasional remplissage related complication where the anchor can pull out. I have one patient who tore their cuff through one of their remplissage stitches, but for the most part, the remplissage works great and does not appear to have a lot of complications. Okay, so these are the issues with measurement, which is what angle do you choose on the humerus? So ideally, you should be choosing the black line, but I'll tell you most of the time when we make some of these measurements, we're making them with the red line. The other issue is, what is the angle of the Hill-Sachs relative? So some patients, because of the nature of their dislocation, the position of the arm at the time of the dislocation, that changes the angle of the Hill-Sachs, and then that may have more or less effect upon their day-to-day stability. So as a result, there's not a lot of agreement as to what is on tract or off tract. And this is data from a study we did showing that agreement is poor, which is to say there's like 20% of patients as to where we disagreed as to whether it was on tract or off tract. And we actually found in our study that it wasn't even that predictive of whether the shoulder dislocated again. In fact, it was not nearly as predictive as bone loss, in part, I think, because we don't agree as to who's on or off tract. So this is where I'm at right now, which is that if there is a Hill-Sachs and I can get the scope into the Hill-Sachs, I'm just doing the remplissage. So I'm not making the measurements anymore. If I can see the Hill-Sachs with the scope, then I'm doing the remplissage. So this is my overall algorithm, and I've tried to present all the research, and then I'm going to tell you this, which is hopefully based upon all the research, which is if you come in and you're under 22 years old, contact collision athlete, recurrent instability, or bony Bankart, any of those things, then I'm recommending to you that you get a surgery to stabilize your shoulder. If you're none of those things, then I'm saying we're going to get you into physical therapy. Get out of your sling as soon as you can. If you have another dislocation, you let me know. Otherwise, we'll see you when we see you. So if you have surgery for this, I'm always getting advanced imaging. So I'm not taking anyone to the operating room based on x-rays alone, and I'm usually starting with an MRI. If the MRI shows that there's clearly bone loss, then you need a bony procedure, and that's either the lateral J or the distal tibia, or maybe it's the arthroscopic lateral J if I ever figure out how to do that. If there's clearly no bone loss, then you're getting a labor repair, and then during the labor repair, I'm trying to navigate into the Hill Sachs. If I can navigate into it, then you get a ground massage. Okay. If there's no bone loss and there's no haggle, there's no labor repair, usually there's a haggle, and we'll try and fix that. And I've fixed those open and endoscopic. They're much easier to do open, but they can be fixed either way. So this is basically my algorithm. Okay, and then basically this is how it works. Generally, this is shoulder instability in my practice. I have follow-up on 163 of the 272 stabilization operations I've done in 2 years. And generally, these patients do pretty well. People generally say that it's about an A- shoulder. Reoperations are infrequent, recurrences are infrequent, and people are pretty satisfied with it. So generally in the short term, if you respect bone loss in high-risk patients, these patients do well. The problem is in the long term, and I do tell patients this, if you look at all the long-term studies that have been done, it is pretty clear that about half these patients will get arthritis later in life. And that's like 25 years later, kind of later in life. So there is this problem that I don't think that our operations really solve. I think our operations are good for stabilization. I don't think that our operations are pretty good for preservation of the long-term cartilage status of the shoulder. Oh, that's okay.
So the only, for me, the algorithm is pretty much